Good evening, everybody, and thanks to the organizers for giving the chance to speak at this forum. I know this is last session and you have had a long day and everybody is waiting for the dinner, so I'll be just taking not more than maybe 5 to 7 minutes. My colleague, Dr. Neeti Agarwal, is not here, so I'll be making the presentation by myself only. And I think we have been discussing since the morning that only a few patients of peripheral artery disease do have symptomatic involvement. Most of these patients just go in for investigation for some of the other diseases and then you find out they are having some problem of peripheral artery disease. The problem is much more compounded in patients with diabetes, especially because all these patients are having pretty long duration of diabetes and they are having some amount of concomitant neuropathic symptoms also. So really to differentiate between the neuropathic symptoms or the arterial system or a neurovascular symptom, neuroischemic symptoms is of paramount importance. We will not be discussing that because of the paucity of the time. We'll be just discussing about the management of diabetes in these sort of patients. And even in those patients who do have symptoms, it's really very difficult to identify whether they're having peripheral artery disease or not, because we really have to differentiate, as I said, between the neuropathic symptoms or the vascular symptoms or the combination of both, which most of the patients are having because they are having a pretty long duration of diabetes. So as was talked in the previous two talks, the speakers who spoke on the management of blood pressure and the management of lipids and diabetes, they said that peripheral vascular disease is definitely much more common in diabetes because it's basically an atherosclerotic vascular disease. The end point is that most of the patients land up usually with some amount of limb amputation, especially the lower limb amputation, just cutting down really the quality of life and also including the cost and the economics involved in the management of diabetes. The cost and the economics, once you develop the peripheral artery disease, this jumps to more than 10 to 20 times, which are usually involved in the management of type 2 diabetes or type 1 diabetes. And again, there's an increased risk of the cardiovascular symptoms, the CADs, nephropathies, retinopathy, and ultimately leading to increased incidences of mortality. So are there any recommendations for screening? Like all the societies, the endocrinologists or the diabetologists, they do have a society, its name is the ADA. It usually gives out all the guidelines relating to all the aspects of diabetes once every year. It has also given out the guidelines regarding how to evaluate the patients of peripheral artery disease or how to suspect any patients having peripheral artery disease. The recommendations are very basic and simple. Those with more than 50 years of age, they should have an ABI test repeated once every 5 years, even if they are not having any symptoms. And those less than 50 years of age, if they are having any comorbid symptoms, you have to treat them accordingly, as simple as that. The most important point is, in each and every clinic visit, you have to just look at the feet of the patient and you have to just try to catch the importance of the involvement of the diabetic foot or the symptoms of the PAD very early in the course of the disease. The management is simple, what we call as the A, B, C, D approach. The B and C part I've been taking care of, so I'll be just taking the A and the D part. That's the maintenance of the blood sugar, the long-term glycemic control, which is indicated by HbA1c, and the diet and lifestyle part is really very important. For the diet and the lifestyle part, the basic thing is smoking cessation. All of you know that's what role smoking plays in the deterioration or in the progression of PAD. So all the patients should be counseled regarding cessation of smoking, and it should not be like that. Okay, you have to reduce the smoking, then stop it. It should be okay. You have reached the end point. If you want to save your limb, just quit smoking. Otherwise, you're looking at losing your limb at all. Healthy eating is definitely to avoid, especially in those patients who are having severe degrees of dyslipidemia or who are on patients the blood pressure as well as the lipid lowering medication. They have to be advised regarding the diet part also. As far as the exercise goes, you have to be really individualizing the amount of exercise that these patients have, because due to claudication or other symptoms, they might not be able to take the due amount of exercise which is recommended in these patients. Foot care again is of paramount importance. At each and every visit, be it at 3 months, 6 months, yearly, whatever, you have to emphasize the self-care of the foot, as well as a podiatrist should be looking at all the diabetic patients who are having some or any amount of the feet problem. For the glycemic control, we have a good marker of long-term glycemic control, that is the glycosylated hemoglobin. AD recommends it should be less than 7% to indicate a good glycemic control. But again, the key point here is the HbA1c should be individualized. It's not like that all the patients with PAD should be having an HbA1c of low. The key point is individualization. For example, somebody is having a long-standing diabetes, you try to go in for and really bad HbA1c and you try to reduce the HbA1c very quickly, you are exposing the patient to unnecessary hypoglycemia, and that might lead to exacerbation of these symptoms, especially if the patient is having involvement of the cardiac involvement or the nephropathy. Oral anti-diabetic agents, generally whatever you use in normal diabetes, you can use the oral anti-diabetic agents. Just watch out for the complications. And the complications may be related to nephropathy, maybe the cardiac involvement. Like for example, if the patient is having some element of angina, you have to avoid the PPAR gamma inhibitors. If the patient is having some amount of renal dysfunction, you have to be really careful by using metformin. Sulfonyl areas and the neo class of drugs like the DPP-4 inhibitors or the injectable like the GLP-1 are really good options. And obviously insulin, there's no comparison to insulin if you look at all the drugs which are being used for the management of diabetes. The key point is to avoid hypoglycemia, especially because most of these patients are having really bad comorbid symptoms. So you have to pick and choose that therapy which avoids the hypoglycemia, and you can use insulin in a right amount of doses. You can use the OHs which are known for causing less amount of hypoglycemias. So ultimately, and this is my last slide, ultimately you have to adapt a multidisciplinary, well, it has to be a holistic approach. You have to involve an endocrinologist or a diabetologist at your hospital. You have to involve a cardiologist, a vascular surgeon. You have to involve the orthopedician also if you're looking at the amputation of the patient, or the vascular surgeon who is looking after this part in your hospitals. And the most important part is you have to involve the foot care team. In our hospital, we have a separate foot clinic looking after all the patients of diabetes who are having some amount of foot problem. Education and awareness is definitely more important, and hyperbaric oxygen therapies, all these things are really specialized healthcare, mainly available in tertiary care hospitals. So that will go. Thank you.